Okay, I'm just waiting for the presentation for a second. Meanwhile, I can say that I'm very grateful and honored that you invited me to your conference, and I hope you're forgiving me that I'm not speaking in Portuguese. I may offer French a little bit and Latin probably, but I think English is the first choice as of today. Porto is a city that has some memories for me and to me, as one of the first board meetings I had in 2010 actually, when I was elected by that time as postgraduate training chair of the European Junior Doctors, was here in Portugal, exactly in that premises in the building of the Ordem. And if I remember correctly, it was under the presidency of a Portuguese colleague, Bernardo Bolen Pinto, by the time. Also, Porto has a history within EGD. Just to remind you, we had, I think, 2 meetings already here. One of them was in 2001, where we released the 25-year book and celebrated 25 years of European Junior Doctors. And I may remind you that next year we have the 40-year celebration. Maybe there's an opportunity to have this also in that wonderful city. I must say I'm very happy that I, yesterday evening, redid a little bit my presentation and took a couple of slides out, because the problem as third speaker is always, you want to talk about things that always are mentioned. And there were a lot of things in that were mentioned, especially from Alberto, who reminded us and Amy. I had the opportunity to be an Amy keynote speaker in 2012 already, and by the time I realized that there is a lot of things that are common in undergraduate as well as postgraduate training, even more. The title of my speech by that time was The Continuum of Medical Education. The question we are facing as of today is, can we still be like we're separating in undergraduate, postgraduate, and CPD, CME, what comes later in that presentation, or is it all over and still one continuum we're talking about? But these are all things aside, and I want to focus a little bit on the question of what is going on in postgraduate training, the medical act, the working in our field. I've seen a lot of things regarding the undergraduate training, regarding simulations, regarding, you put it in 3D, you put it on puppies, on simulators and all that stuff. And there's one thing, we in Germany just had a cooperation with Lufthansa for one reason. The pilots are doing all these simulations too, but indeed their simulators are moving and they're resistant. That's the one difference we not have still in our undergraduate medical training. The puppy is there, it lays down, you can easily try to work on the puppy. It's not jumping up and running away or resisting what you do. That's the major change. When you come to postgraduate training, you all of a sudden deal with a really patient, and you have to take your own responsibility. You have to treat the patient by yourself. That is a little bit the dream we had, I think, when we started. We're coming, we can help the patient, we can heal him, and everything will be fine. But this is not what is happening anymore. It changed over the year. The view on the doctor is much more different and differentiated in these days. It may be that 50 or 60 years ago, everybody say, we go to the doctor and everything is fine. In these days, they're coming, Mr. Doctor, I Googled. I know what I have, and I know what you have to do. That changes a lot. So the way to be finally a physician is a very, very long way. And we heard a lot about these ways, and these are the slides I just summarized a little, and now I'm very happy that I did. We have the undergraduate training, 5 to 6 years, differs from country to country, all over Europe. Long, long way, and as we heard, a long things to do. Then we have the postgraduate medical training. Another 6 to 8 to 12 or even more years, depending on the specialty, super specialty, whatever you want to have. If you just calculate that in your mind, 6 plus, let's say 8, 14 years to be a specialist, and then still not yet finished, then, and Joao will talk about this a little bit later, you start to recertify. Continuous medical education, continuous professional development, a lifelong thing we are doing and we are dealing. So basically, if I focus on postgraduate training and what is the medical act in postgraduate training, it could be very easy. I think you in Portugal, as I'm coming from Germany, as you heard, in Germany and all over Europe, we have very detailed curriculums, what is to be done in postgraduate medical training. This is one of the curriculums I'm in. I'm doing orthopedic and trauma surgery. It says I have to work on the shoulder, I have to work on the hand, I have to work on the hip, and I have to do 10 of each of the regions and 10 of the procedure. So at that point I could say postgraduate training, very precise, very easy. Thank you, that would be the end. But is it the end? No, it isn't. For sure not. What is going on and what we are dealing in the European Junior Doctors, besides the things we already heard of management, leadership, education issues, we have a huge issue to face and to discuss right now, which we started already in 2012, 2013. We're dealing with task shifting. We are not the single one that performs procedure on the patient. We have a lot of other healthcare professionals along with us. You mentioned the interprofessionalism already. So we're not anymore the doctor that treats the patient, we are the team that treats the patient, and the doctor is moving towards a little bit more the leader of a team. And every member of the team has special tasks. So we ask a member, how does this affect your life as junior doctor? First of all, we started to ask, is it existing in your country? And from the countries in that survey participating, it was just 15 right in the meeting in that point, except for 3, task shifting is running. Meanwhile, I know that in Malta, Croatia, and in Spain, they also started huge task shifting issues. It is mainly driven, and that's the thing we have to take a little bit in our mind, it's mainly not driven for, let me say, treatment or maybe some other things. It's often driven, and you will see that later in the presentation, for cost-related reasons. To whom tasks are shifted, that's varying. Mostly we have specialized nurses or nurse practitioners. But if you go back a little in history, that started not in the last couple of years. I was 2 years ago in a museum of medical art, and we found a blood pressure measuring a device, and it was written on that to be used by doctors only. It was from the 1930s, so it was very old. Indeed, these things are doing today computers even, so not anymore nurses. So shifting of tasks is something that happened a huge time and a long time already. We're talking about the midwives. They took a lot of tasks from the gynecologists over the years, which is, in our eyes as of today, natural. We also asked what is shifted, and here it got interesting. We had a task shifting workshop of the European Junior Doctors in Amsterdam, and I must admit it was very confusing to hear what is shifted even in some countries. For example, in the United Kingdom, coloscopies, gastroscopies are done by physician assistants. In Germany, we have echocardiograms taken by physician assistant. In Amsterdam, we have discussed the Dutch system of prescribing of medication to patients, standard regular medication, by the nurse practitioners. And if you go all over Europe, you will see that a lot of tasks we would naturally say this is physicians' or doctors' work are shifted to other ones. That was the first thing we discussed in our workshop, and it was a long discussion going on these things. I have some comments that were here made in that context. You can see what I told already, some things like the bladder cannulation, for example. I could never imagine that was a physician's task. But 25 years, it was only the urologist in most of the countries who was allowed to do this. Now it's a nurse task. For my generation, this is natural and normal. Maybe for the people that are slightly older than me, they remind it differently. New shifting things are coming on, and also we have some problem with, as you said, nurses are starting to prescribe in chronic medication. That was the Amsterdam topic, and I remember Diana Fernandes from the Portugal Medical Association, who was there, that especially in Portugal you're refusing and resisting, as we do in Germany, and as I think a lot of people all over Europe would do so. We just ask another thing. Is it formalized by law, or just does it happen in any way? Could also be shortness of healthcare professional, could also be some other reason, cost reasons, or just a hospital director says, I don't want to hire more doctors, I just hire more other, maybe cheaper people to work. And that was something that I was kind of thinking, we should change that. Only in half of the countries participated in the survey. They could state it's formalized. It's a real progress going on. Also, guidelines and protocols, interestingly, in most of the countries there are existing, but not for the task shifting itself. They're usually existing for the professions that want to have tasks. And here it's getting interesting for us, especially as trainees. If you have, for example, nurse practitioners, they're making their own guidelines, what they have to do, Then they all of a sudden write in, we want to do central venous lines. It's in their guidelines. And then they say to the state, we wrote it in. The central intravenous lines are now nurse tasks. And what are we as doctors doing? We're just sitting there and saying, maybe we shift that task. We also asked, where does it take part? Basically, overall, except for Finland, where only in GP issues that is taking part. Another question that we raised, and that is really interesting in that field, who stays responsible? The task itself sometimes is shifted with the responsibility and sometimes is shifted without the responsibility at the end, which is a huge issue too. And here comes the clue. Will generally responsibility remain with the physician? Yes. In every country you ask, after a task is shifted, still we are the one responsible. So what does that make for us? A very easy thing. If you are responsible for a task, you have to at least understand what the task is. Maybe you have to had it once in university. You had to be trained on the task, because if you just shift it, you tell someone do it and you stay responsible, how could you control if it is still correctly done? And that is a huge issue affecting our postgraduate training. If tasks are done by other professions, healthcare professions, especially in my profession, orthopedic and trauma surgery, we have the huge issue with physiotherapy. If I talk to my physiotherapist, it's always the problem that she doesn't know a lot more in physiotherapy than me. But in general, I have to understand what she is doing, because if I don't, I can't make the correct ordering of the tasks she has to do. That's the question, and we have to take a little care of that, because you will see another slide. Who remains responsible for the diagnosis? Who remains responsible for the treatment plan? That's one question that is in some countries already questioned, and by the time in some countries the PA already take the diagnosis, puts them first in the chart. Then not we as doctors are anymore the ones that are responsible, it's the PA that makes the first diagnosis. Happens is a problem. One thing, does it create less work for physicians? That's the interesting thing. Yes, so everybody indeed would be happy saying, okay, I have less work, that is a good thing. Does it improve the healthcare in your country? People say mostly yes. That has to do, I think personally, because we have done a little bit more healthcare professionals around with us. Here comes it interesting for us as European junior doctors, and that was the reason why we conducted that survey. We asked if this task shifting progress is interfering with our training. The countries in that it interferes, you heard already about. In the Netherlands, we have a lot of task shifting to nurse practitioners going on. They are doing these ECGs, they are doing the prescription. So it directly interferes with the colleagues in training. In some countries, in Germany, France, task shifting is taking part on a very small level, so it does not yet interfere. So I would a little bit reinterpret the question, does it interfere yet with your postgraduate training? And if you would ask, will it interfere in future? I assume that most of the countries will say, oh yes, it will. You cannot simply learn a task anymore that is shifted to another profession. It is out of our profession. Does task shifting decrease the training opportunities? In that case, no. It was interesting. We discussed that figure a long time, and I was thinking, okay, then everything should be fine. When it comes down to the baseline and to the bottom, you will see that these tasks shifted are usually the ones that are performed directly on the patient. It was very difficult, and I must apologize, we don't have exact figures on that, but you can imagine how big Europe is and how different this is in countries. But just make a couple of examples. If coloscopies are shifted, I can surely say that one thing is not shifted, the paperwork. The work of the patient is shifted. The paperwork stays with the physician. The discharge note of the patient that was in the coloscopy has to be written by a doctor still. So we're moving towards bureaucratic work, while the patient work is done by other professions. We also asked if they are merged with the training programs, and in some countries already these programs of the so-called shifted professions or the healthcare professions are partially merged with the training of junior doctors. That has to do that in some countries the Bologna process is implemented, and then they have a bachelor. A bachelor is then later on the PA or the nurse practitioners, and if you continue to the master and the final year, you may then be the physician. That is the figures we also ask for. Do we experience an increase in the non-medical workload? Yes, we do. And here comes it down to the clue. Postgraduate training is directly affected. We have figures from over Europe that, for example, in Austria, in postgraduate training, the amount of non-patient related workload, means non-on-patient, is 43%. Germany, it's 37%. Finland, 41%. So if you ask your colleagues around, I don't know the number of Portugal, I'm sorry. If you ask around the European Union, you will get more and more increasingly figures about the non-patient workload that is hitting us in postgraduate training. So one of the core issues in the future, and I think that is a little bit what you try to do in undergraduate medical training, you have to train with the patient issues, not with the paperwork, not with the paperload, with the bureaucracy. You have to be on the patient. 6 years, that's the average of training in Germany. And if you then take 37%, that means basically two and a half years, you're not at the patient, you're just at your desk. I think that is not acceptable anymore in future in postgraduate medical training. Also, do such tasks reduce time available for the patient-related tasks? Clearly, yes, they do. We have some comments from the survey. We have the problem that in France, for example, the responsibility always stays with the doctor, but I already mentioned that. And we have some inverse task shifting. That's something with the working hours, junior doctors have less time for the patient, and then the nurses are taking over some of the things. The conclusions we are having on this is very difficult and very diverse. In those countries you have physician assistants and nurse practitioners already implemented. People are, and that is very strange, since then there are like 10 or 15 years already in place, used to it. If you ask your colleagues from the Netherlands, they cannot imagine how it is in other countries because they are used to it. They start 3-4 years ago with the training. And if you ask them, are you performing still the echocardiogram? Whoops, that was just the water. No, the nurse is doing. So how should I know how to perform the task? How should I be trained in it? And if you then come, I don't know how this is in Portugal, if there's a Portuguese cardiologist over here, if you come to Portugal, European Qualifications Directive makes it possible, you come over here, you are not able to do an ECG or the coloscopy, other things we discussed about. So I think one of the core conclusions will be that we have to make a comparable European definition of what is after postgraduate training the standard. It must be not the same curriculum all over Europe, but it must be something that is comparable so that we know a physician from Germany, UK, Netherlands, Portugal, let me say an orthopedic and trauma surgeon like I am, has the same qualification all over Europe. That's the first thing we have to do. One of the conclusions we're already thinking about. The second thing is we have to be very careful when it comes down to task shifting in what we are doing, because we are the doctors still. We're the one with the responsibility for the patient, and we are the ones that at the end must be able to understand the procedures performed on the patient, not just reviewing charts. I was always told in medical school, you're treating the patient, not the lab results. That is something you have to learn over the years. Just go away from the paperwork, go to the patient and ask the patient, how are you? Important questions we sometimes forgot. How are you feeling today? Not so good, good. These are things we have to learn a little bit more. If we let it happen that in future the team around us performs all the procedures at the patient and we are just doing the paperwork, I think we have a huge issue in future. Finally, we will go on with discussing on that point, and European junior doctors are discussing for a long time these issues, and if I go back in some minutes, I realize that we discussed it 5 or 10 years ago already. In the name of the EGD, I want to thank you for being here, for raising that issue. This is a picture from our last meeting, which we held in Oslo. One person is missing, Mariana. She couldn't attend this time, but I want to also thank the Portuguese delegation for all the effort done in the European Junior Doctors for the years. It was a pleasure for having you there all the time, and it will be in future to have you with us aboard. And as you see, your young colleagues are enthusiastic and are supporting and working on the interests of junior doctors all over Europe. Thank you.